Okay. All right. Welcome, everyone. We're so glad that you joined us for this program on healthcare, access to healthcare in the time of COVID. A member of our league, Pat Norman, has agreed graciously to be our moderator for this evening. And so we'll turn it over to her at this time.
I would like to begin by saying good evening myself, and welcome to everyone to the League of Women Voters panel discussion with local healthcare providers from FHN and SSM Health, formerly Monroe Clinic. My name is Pat Norman, and I am, someone told me my arm was twisted. It really wasn't, but I am happy to serve as the moderator this evening. And I am happy that the League of Women Voters Committee decided to ask the NAACP if they would co-sponsor this evening. So we're happy to be here. Everyone on the call will be muted except for the panelists and the moderator. Tonight's questions were prepared by the local host committee and were submitted to the panelists prior to this evening's event. And the panelists will respond to each question. In order to hear the responses for all questions, panelists, we ask that your remarks be limited to a maximum of 3 minutes. If members of the audience have questions, please submit your questions in the chat. And as time permits, we will have our panelists respond to your questions. Again, the topic for this evening is the COVID-19 pandemic's effect on healthcare access now and in the future. We will begin with opening remarks from each panelist. We'd like for the panelists to introduce themselves and describe their role at FHN or SSM Health. Tell us how the COVID-19 pandemic affected access to healthcare for both COVID care as well as care for other conditions. And in your opening remarks, include how the National Healthcare Staffing Challenge has affected your organization so far, and what effect do you expect it to have in the next couple of years? President Miley, we would like to begin with you.
Thank you for having me here today. My name is Jane Curran Miley. I'm president of SSM Health Monroe Hospital and SSM Health Monroe Clinic Medical Group. As Patricia said, those are recent name changes. I think everyone simply knows us mostly as Monroe Clinic. Regarding the first question you asked to speak to is how has COVID pandemic affected healthcare? The pandemic has truly challenged the delivery of healthcare, both from a process perspective and also from a volume perspective. At one point, 55% of our beds were filled with people who had COVID, and the rest of our beds were filled with people with other illnesses. Normally, healthcare facilities don't staff to be full all the time. We staff to an average census, and we have some ability to flex here and there. But I kind of make it equivalent to saying, if you bought a dining room table that could seat 8, but you only bought 6 chairs, because that's what you usually have, when all of a sudden you get to 8, you have to do things differently. And that's really what COVID challenge healthcare to do, is to say, how do you expand to these really high volumes of healthcare for such a long period of time? You know, usually you get the flu season, which is a few months, or you get something else that happens and it's a shorter window. This has been 2 years, and it's been very, very challenging. But I really feel that the team has done a tremendous job in adapting throughout this journey to maintain high quality care. And they've taken that very personally, but that's tough to maintain the same quality levels and commitment when your volumes are so high. But again, they did a great job. But the other part of it is early on in COVID, everyone did such a good job of telling the public, don't go to the hospital unless you have COVID. And so people stopped coming. So what we're finding now is that people have delayed care for so long that when they're finally coming to the hospital, instead of catching a lung cancer at, say, stage 1, we're catching it at stage 4. They're first coming in to be seen when they're in the last stage of that cancer. And that's devastating. It's more costly for the individual. And that really has made it difficult. So as we look at it, it has put a limit on people coming in, but part of that limit was directed by our government to try to say, don't come in unless you're sick, but people put off care too long, and we're seeing the consequences of that. And we will see that for the next few years. And then the other question you asked is, how are the staffing challenges? Our staff are tired. I think Kathy will tell you the same thing. They have worked incredibly hard during all of this. Some have chosen to leave the field, some have chosen to retire, but the majority have chosen to stay with it. And they are doing things very, very well. But one of the things that the COVID crisis taught us was we had to do things differently. So staff, we started working people at the highest level of their degrees and licensure, and having other people do things that technically an RN or a physician didn't have to do. And that helped us manage the volumes that we were seeing.
Thank you. We're going to move on to Executive Vice President Martinez.
Good evening, everybody. I hope everybody's safe this evening. Would like to extend my thanks as well for inviting us to have this opportunity to talk. I am the Chief Operating Officer, Chief Nursing Officer at FHN. We joked before we gathered everybody, I have a lot of titles, and it really means that I'm here for the operations of our organization. I work side by side with our president and CEO, and I've actually been what's called the incident commander for the last 2.5 years as we've gone through the pandemic. So working daily with our team on how to best care for our community. Access to healthcare has been changed dramatically since the pandemic, and all of you have experienced it. We had office closures, as Jane mentioned. We have people who are scared to go to the emergency room. They're scared to go to office visits because of potentially being exposed or, some of the challenges we had in the beginning about all the unknowns about COVID-19. And then we introduced virtual visits along the way. So we uprooted in the midst of a pandemic the way that we deliver care. And as mentioned previously, this impacted not only our COVID-19 patients, but it impacted preventive care. So many people didn't go and get that mammography that they needed. They didn't get their immunizations, their bone density. Other people didn't get their chronic care management like they should have. So diabetes for some individuals is out of control, unfortunately, now. And then we also saw a big shift as we talked about end of life care. And many patients and their families decided to do some of their hospice care at home versus nursing home because of the restrictions for visitation, et cetera. So we really uprooted a lot of different things at the same time. And unfortunately, we're starting to still see the remnants of that. We still have individuals that have sequelae, as Jane mentioned, that they shouldn't have because they postponed their care. And we have to regain trust of our patients and bring them back in and figure out how to meet them in the settings that they feel most comfortable at. We are happy to see some people starting to return because that really is going to impact the health of our community as a whole, and we'll continue to work towards that. Our staffing situation has been impacted very much as SSM Monroe. We had people who decided on early retirements. We had other individuals who might have been mentally or physically fatigued along the way and decided they needed to step away. We've also had some people who were caring for aging parents or a sickly child who decided that they didn't feel the risk of possibly bringing COVID-19 home to their family member was the risk they wanted to take, and they made some different decisions. All in all, that's on top of a massive nursing shortage that was supposed to hit in a couple years that we were preparing for, but it all got accelerated. We've never had a time in healthcare where healthcare shortages have been across the board. So from environmental service workers to keep you safe so you don't get an infection while you're in the hospital, to food and nutrition, to that nursing assistant, to the medical assistant in the office practices, it's been compounded in a huge factor now. And now we're having to redevelop our delivery of care models. And that's one of the things that I think we have great opportunity to really improve the care that we deliver across healthcare, no matter what organization, and transform that patient care and patient experience.
Thank you. Dr. Parks.
Hello, everyone. And once again, I want to echo the sentiments expressed before. I am grateful and honored for the invite to be a part of the panel. So I am currently the chairman of the Department of Hospital Medicine at FHN. I also serve in the capacity of the medical director role for community health. And over the last 2 years, I've served on the physician COVID advisory group. So to jump right in, some of the information I agree with Kathy and Jane about all of the things that were mentioned before in terms of how access has been affected. And access to healthcare has been affected likely in several ways. First and foremost, one of the things that affected us was the extreme unknown with the pandemic, how we're going to contract it, how infectious was a illness as a result of this infection. But then in addition to that, there was this overwhelming sense of fear around all of this. So individuals then began to fear coming to healthcare access points, for instance, the hospital. As we mentioned earlier, one of the things that was a success, but also a negative, was the fact that there was this overwhelming message on the national front, which transferred to the local front, to only come and seek care if, in fact, you absolutely needed it. So that sent the message to our patient population that, oh, there is something unsafe about our access points. So that was one of the big things that we had to overcome, fear. The second, and probably an additional aspect, organizational wise, we were faced with how do we continue operations in the ambulatory setting for health promotion and prevention, and how do we do it safely, knowing some of the same things that there were unknowns in this practicing environment with the pandemic looming over. What that did was that reduced some of the access points and availability, because we wanted to make sure that we were providing safe environments all around through the spectrum, and reducing, for instance, patient wait times in a waiting area, but also in addition to that, reducing the available slots for patients to make sure that we were providing the safest environment that we could provide. As Kathy mentioned, one of the positives that came out of this was the aspect of telehealth. It's been around for a while, but it wasn't widely accepted. So organizations like our local organizations had to be very nimble and stand up a telehealth service and doing it effectively so that patients would still have certain access points, acknowledging the fact that nothing beats a primary care provider evaluating health promotion and prevention, getting patients in for the screening colonoscopy, getting patients in for the screening mammography, and then setting them up for a diagnostic study. So those are some of the things that we knew that was a limitation to our new environment of practicing healthcare. And lastly, how has it affected our workforce? Once again, as the other panelists mentioned, we had almost a three-prong effect. We had people, because of uncertainty, healthcare professionals decide that now it was time to retire. Some of them, secondly, thought that, well, I have, as Kathy mentioned, aged family members, and I don't want to put them in a situation where they're at risk. So they were leaving the healthcare profession. And then lastly, one of the things that was overlaid for all of the problems was the fact that we were facing a nursing shortage, but also provider shortage at that time. So you lay all three of those things over, and then you have those challenges. I'm happy to report that I was very, very pleased and continue to be pleased with the members of the healthcare team that showed their dedication, devotion, and providing the highest level of care through this time. It has been difficult and it's been challenging, but those individuals served, and they served every single day.
Thank you, Dr. Parks. We're going to begin with the next question, and we're going to ask Chief Operating Officer Martinez to respond first. The question is, have you seen any disparities in different demographics related to healthcare access and treatment during the pandemic, both for COVID-19 specifically, as well as for other conditions? And if you would follow up with why or why not? Why don't you think this has occurred, if in fact it has?
Sure. So very early on in the pandemic, we mirrored many areas across the country. And the population that really came to the forefront was our Latinx population. We had a significant outbreak of COVID-19 among that Hispanic population across the board. Many contributing factors to that: close living quarters, close working quarters. There was a lack of trust with healthcare and the health department officials, right? We didn't have great relationships that were established to help us get through a pandemic, and that reporting structure. There were a lot of people asking a lot of questions, especially in the beginning, trying to gather information, which was very scary. And that took a lot of work to establish that trust and get to a very different level of, this is why it's important for us to have cooperation and to be able to work with you. We want to help you and your family members. When I go back 2.5 years almost, and I look at some of our early hospitalizations, we had a lot of patients that were from this area. Then we started to see a little bit of a shift, and we started to see a rise in some of the African-American patients getting hospitalized. And a lot of that started, as we started to correlate that, really had to do with some of the comorbidities that were existing. So some of that diabetes, the hypertension, et cetera. And then very quickly it normalized. And what we've learned about COVID-19 is there is no rhyme or reason to this disease. It will take down a 30-year-old just as quickly as it will take down a 90-year-old. And it started to very quickly dissipate across everybody, right? There was nobody that was immune. And I feel that the beginning was a lot of identification of, people coming forward. We had, again, not the ability to get all of the safest conditions together. When you live in a large structure and you have a lot of different family members, COVID-19 is going to populate very quickly. So I think we learned some very quick lessons early on. FHN, and I know Monroe Clinic did as well, worked very closely with our health department, trying to get help to those individuals. But we've learned a lot. And I think one of our areas that we always will continue to work forward with is those disparities, and how do we get better relationships outside of the pandemic.
Thank you very much. Dr. Parks, would you respond?
Yes. So I think one of the things that the pandemic exposed when it comes to issues like this is it accentuated some of the gaps that we had in healthcare. Obviously, social determinants, living situations, healthcare underlying comorbid illnesses as well. As Kathy mentioned, one of the glaring things that we noticed that this was initially a spectrum, that initially we started to see quite a few Latinx patients, and then we saw the patients with significant comorbid illnesses like diabetes that have been uncontrolled, patients with uncontrolled hypertension. And one of the big groups early on that we saw was obesity. One of the things that we knew is that we had to get that message out. We had to get the message out of not only being mindful of a living situation and how do you keep that living situation healthy, even though one or two of the family members are afflicted with COVID. In addition to that, we also started to educate and blast on every aspect of healthcare information that we could. What are some comorbid problems? What makes individuals at risk, so that we can educate them so that we're not seeing them in our healthcare system later on in that disease process where the severity of illness is at its highest. And as Kathy mentioned, this was an illness truly that had ran the spectrum and continues to run the spectrum. There's no rhyme or reason for who's going to get ill. We had patients in the hospital. One family member was afflicted and they went home in 7 days. Another family member was afflicted and they were on a ventilator for close to 3 weeks. So there was no rhyme or reason for it, but we learned a lot. And one of the biggest things that was a take-home message for me was the aspect of, as soon as we gathered more information, how do we disseminate that information for our community's overall health and wellness?
Thank you. We're going to go to President Miley, if you would respond to that question.
Sure, and I think we're very fortunate in both the communities that truly anyone who shows up at our doors will treat. So in that way, there's no discrepancy in terms of how anyone's treated. I think the issue comes down, as Kathy pointed out, is there is a mistrust on healthcare in some communities, because healthcare, I think the tactic a lot of times is taken in the past is, we know what's best for you to follow. And Kathy and I have been having conversations on, are there ways for us to present this differently and present healthcare to people in a way that they want to receive it versus how we think it should be delivered. But one of the things the pandemic really pointed out, because we've always been very open door. You come to us, we'll take care of you. Well, one, as Dr. Park said, people couldn't come to us. They didn't have transportation, or they, family issues or whatever prevented that. But we really made an effort, especially as soon as vaccines were out, to go out into many of our minority communities and start there with our vaccines. In fact, that was some of our first places we went to make sure we were serving those who don't come to us. And we also did something very different that we've never done before. We've always communicated directly with our patients and vice versa. We do same as FHN with social posts and things like that, but we weren't reaching everyone. So we did something where we took basically a newsletter to businesses, and we put it in English and Spanish, and we distributed it out to local businesses for them to share with their employees, feeling that the employer might be a more trusted source than healthcare. And we partnered with the local county health departments in order to do that. And it really was very effective, both for the employer, but we found people more willing to come in. We went out to farms where we had a lot of migrant workers to make sure that they were getting vaccinated. We went to some of our city parks where there were festivals for celebrating different cultures to make sure we were offering vaccines there. So we really were trying to get that effort there, but even with all those extra steps, we still have a lower vaccination rate among a lot of our minorities. And again, I think it goes back to Kathy's statement of there's mistrust and we have to work to build that back.
Thank you very much. Thank you very much. At this time, we're going to hear from the Chief Operating Officer, Martinez.
New question, Pat,
Yes,
or?
new question. Have you experienced challenges related to insurance coverage of your patients during the pandemic? And if so, could you please provide an example or two in describing the types of challenges that you've experienced?
So I think across the board, insurance challenges were very unique to the pandemic in that the government really stepped in and made some, pretty large statements about what could be billed, what couldn't be billed. How does someone get care and pay for their care related to COVID-19? So I'm going to twist the question a little bit and maybe cheat a little bit. I think two of the areas that we really struggled with and continue to struggle with today, the one big area is our patients that are insured, no matter what their insurance carrier is, whether it's Medicaid, Medicare, private insurance, we're having very long lengths of stay because of long-term care. We're really not able to get our patients out to those skilled nursing facilities, et cetera. Again, they're impacted by staffing shortages and COVID as well. But that's really starting to impact the care that our patients are receiving. We're having to change, again, our delivery model because we're doing more rehab within the acute hospital setting. And then that's having a domino effect because we have patients in for a much longer length of stay. I'm happy to report that as of today, we've seen that decline in COVID-19 that you've heard about on the news recently over the last 2 weeks. But the other thing that really impacted us was our inability, our lack of ability to transfer those patients who needed higher level of care. So we ended up opening up a second intensive care unit because our patients were not able to be transferred to an academic medical center or even to Rockford to receive that higher level of care. And so that's really where I look at the challenges of, where did we get challenged? Insurance hasn't been as much except for underinsurance, which again, the government is kind of broad stroked right now due to COVID-19. So we'll see what the government is going to learn from the broad stroking. But really the challenges have been much more unique to our patients and the care that they've had to receive as a result of COVID-19 impacts.
Thank you. We're going to hear from Dr. Parks.
Right. So I agree also. One of the biggest challenges that we had was not necessarily on the front end where patients did not have health insurance, right? Because we mentioned that patients who present at our doors, they're going to get care, particularly for the aspect of, from that aspect of the doors are open. They're ill enough to be admitted to the hospital. They're going to get that care. And as Kathy mentioned, the government actually stepped in and provided some support for the healthcare delivery system. So that was not necessarily the issue. The bigger issue that we had was that all organizations were full. All healthcare systems were full. And at the end of that point where we can transition them safely to a subacute facility or a long-term care facility, we couldn't get them there. So that therein lies the biggest challenge that we had, not necessarily coverage for that, but we had no place to transition them to. So we didn't really see the issue of coverage on the acute care side. And in fact, we didn't see that issue present itself until later when we noticed in this pandemic that patients had rather long length of stays. Oddly enough, it became a huge issue during the Delta variant phase of our pandemic.
Thank you, Dr. Parks. We're going to go to President Miley.
Again, for the most part, insurers were not an issue. They really have been responsible and responsive to the needs. And as Kathy talked about, the government did step in and give us some nice broad strokes, which kind of helped with everything. When you think about an average length of stay in a hospital, when you take all the patients that we have, let's just say it's 3 days. We've had patients here as long as 90 with COVID. And if someone's in a bed that usually turns over every 3 days, and you now have someone here for 90 days, that just took up 30 additional patients' beds. So that meant we didn't have those beds for 30 other patients, if you turned it over as every one. And I think that was something that really challenged us. Being what we're considered a community hospital, something new for us is we were getting calls from both states saying, can we transfer into you? We need an ICU bed. And we were getting calls Milwaukee, Madison, Minneapolis. I got a call from as far as Oklahoma asking us if we had an ICU bed. I wanted to give them a geography lesson, but I didn't go there at that time. But that's how desperate people were for beds. They were spending like 5 hours at a time trying to find a bed for one patient. So we were taking an average of 10 transfers in a week, trying to balance that with caring for our community, but not turning anybody away at any point. As Kathy spoke, the skilled nursing facilities had COVID outbreaks. They had limitations with staff. They couldn't accept the patients. We had the patients staying. They would be ready for discharge, but we couldn't find a safe place to discharge them to for up to 3 weeks after they were ready to go home or go to a facility. There were no facilities. And that also really caused problems for us. So from that perspective, again, the insurers were good. It was really trying to get patients to the right level of care that was someplace else so we could continue to meet the patients who are arriving at our doors.
Thank you. This next question also has to do with insurance providers. We're going to begin with Dr. Parks. Can you tell us, has coverage from Medicare and/or Medicaid been experienced differently during the pandemic by either patients and/or by healthcare providers?
Thank you. So this is sort of similar to the response that we had before. Obviously, the payer source did not have an impact during a great, appreciable or measurable impact during the pandemic because we were providing the same level of care. Patients were receiving the same protocol medications. A lot of those medications were under emergency use in the hospital, which means that the government supports its use as long as we follow a certain strict criteria for the federal government. We were providing the same level of care respective to Medicare and Medicaid. One of the interesting aspects, and I think the other two panelists will probably talk about is, and we mentioned it a little bit earlier too, is that normally our length of stays for particular disorders, and this includes a respiratory or breathing ailment disorder, can be anywhere from 3 to 6 days in the hospital. So take that and increase the level of people presenting to your door with a COVID pneumonia infection, and then you're increasing that level of stay from 3 to 6 to 21, 30, 40 to 60 days. So that in essence posed the bigger access issue is because, as we mentioned, the system didn't have that level of redundancy to the point where we had bed availability. And we didn't have bed availability locally, but regionally, our regional partners, our university individuals, our university referral centers, they didn't have availability. So we knew at that point, as Kathy mentioned, we knew locally that we were it, and we were going to have to provide the highest level of care for every single patient. And that's one of the things that I think we were very proud of, that we were trying to do our level best, and it actually showed. So that commitment, that devotion, that the level of healthcare we were providing at the local level was unsurpassed.
Thank you. President Miley, would you respond?
Sure. Medicare and Medicaid, again, like the other insurers, we're doing the right thing. The government realized the impact of the longer stays and did allow some support for healthcare organizations through the CARES Act, which really did help us because we had extra staffing costs, we had extra supply costs, and that just truly weren't covered. And as we talked about earlier, we don't turn anyone away, but that means that we have a lot of uncovered healthcare costs when we're treating all individuals in a community. And so the government did step in, and through Medicare and Medicaid, some of the CARES Act, we're able to get some funding to help offset that. Not completely cover it, but offset it.
Thank you. And Chief Operating Officer Martinez.
Sure. So if you're not aware, in our community, obviously our population is aging. When we look at FHN as a whole, our main payer mix is Medicare and Medicaid. Almost 80% plus fits that. So we've been lucky, and I know in the chat there was a little bit of, could I say what broad stroke means when I said there was a broad stroke? When I say that, the government really looked at a couple different things and said, how do we make this feasible and plausible? And so what should we do across the board, no matter who your insurance company is? And, how can we approach this so that nobody does have a change of care based on their payer? So the government went through some things such as balanced billing. So there was, requirements that we couldn't go and say to somebody, okay, you need to now pay the rest of your bill for your COVID-19 care that you received in the hospital after you were in the hospital 45 days. There's been some different coverage, such as Dr. Parks mentioned, with the emergency use authorization drugs, with testing supplies, et cetera. So the government stepped in a way that they've not before, because usually that's very state run and decisions are very local, and there's not that lean towards universal health care that we took during the pandemic. And so now, we're continuing to see the impact. 20% or more of Illinois residents are Medicaid recipients right now. That number, has kind of flip-flopped all over after the Affordable Care Act came into place. It very much got amplified over the last 2 years because of job loss, income loss, et cetera. The one thing that I am happy with is that we've seen that number increase. And I say that, tongue in cheek, but it means that we have people who actually have that insurance coverage versus not being covered at all. So we have children that are now covered that weren't covered previously. So hopefully we continue to move in some of that, learn some of those lessons we've learned and continue to make sure that we've got coverage for all individuals.
Thank you. And that kind of goes into the next question. And we're going to begin with President Miley. The question is regarding healthcare insurance and how it can be both inaccessible and or too expensive for many of our individuals. Do you think the pandemic has provided any lessons to be learned about the availability of healthcare insurance for Americans going forward?
Absolutely, yes. This is a short answer. I think, part of what occurred is we really started to understand the gap between that you were either overqualified for government health insurance or you couldn't afford private health insurance. And there's a large gap in between. And that's actually probably our greatest at-risk population, as they don't fall into either category. So to get care is very, very difficult. And as I spoke to earlier, we didn't turn anyone away, which meant we chose to take a lot of that care and just basically write it off. It became a loss for us. But again, our goal is to serve the communities, so we're going to do that. It's just tough to keep doing that. So someone had asked the question about the CARES Act. What the government tried to do is they tried to recognize that each hospital was getting challenged with this group of people who kind of fell in the middle a little bit. So they did some calculations proportional to your Medicare and Medicaid volumes that you were seeing, and then trying to look at your uninsured volumes. And they gave us basically a stipend to try to soften that impact that all of us were having. So that's really what that was about, was to try to keep the hospitals afloat so we didn't end up folding under this pandemic, under the crush of the healthcare demands. And we were able to keep doors open so people had access to it. But yes, it absolutely highlighted that we have a gap in coverage and we need to do more. In Greene County, we have one publicly available, it's health insurance, and that's even tough to, on the open market or in the exchange, and that's even tough to afford in that. So how do we make sure we get everyone health insurance, especially that group in the gap?
Thank you, thank you. Going on to Chief Operating Officer Martinez on this question.
Sure. So I'm going to go along the same way with Jane. I think insurance, right before the pandemic was really when a lot of those high deductible plans came out. If you have a high deductible plan, you are very much aware of that right now, because it's the beginning of the year. And every time you go to the pharmacy, you want to just pass out, right? So, we just were starting to get used to that. And then we bring this pandemic along. And truly, I had mentioned earlier, this gave our government an opportunity, and I don't know if it's positive or negative yet, but it gave us a glimpse of universal health care, because we made some very large decisions. Not we, the government, made some very large decisions on who was going to get paid, who was going to, have to pay, and what were the healthcare organizations going to be held to. And I think that's a whole nother panel on what universal healthcare is. But I think it's going to have long-lasting impacts. And it will be interesting to see where the insurance agencies come from, because again, in some of those key decisions made by government officials, our insurance companies are going to get reimbursed and going to be impacted financially as well. And so it's going to be a different playing field as we emerge from the pandemic. And again, as with everything with COVID, and I've said this more times than not, we have to take our learning lessons and implement them and not be foolish and go back to previous ways.
Thank you, thank you. Dr. Parks.
Absolutely. So I want to underscore some of the things that were mentioned before. The pandemic did not cause some of these issues, but it exposed gaps in our healthcare system. Our healthcare system is not designed for the level of redundancy that was required during the pandemic. But in addition to that, it exposed the gaps in coverage for patients as well. Patients were requiring a high level of care. They were staying longer in the hospital, and the cost of care was exorbitant. So we're dealing with a patient population, and I think upwards to 20 to 30 million patients that are uninsured. And I think in the last census report, there was close to 44 million patients who are underinsured. Those are the patients that Kathy mentioned that may have a high deductible plan, or they have out-of-pocket costs that makes healthcare prohibitive. So what the lesson that I think we learned during this part, we knew that the healthcare system was very fragile. We were not only not turning any patient away, but the cost of providing the care was so high that it was above and beyond what could be sustainable for our healthcare delivery system. So the government knew that. And in March of 2020, they actually passed that CARES Act, which then infused some money so that they could support these community settings that we were still providing the same level of care and a high level of care. But if we didn't have that support, the system would break. And as was mentioned, hospitals would have been closing all over the place because they could no longer provide that level of care. So that's a huge lesson. And I think one of the things looking forward is, how do we transfer that type of model into something that is going to be a new model as we emerge out of this pandemic? The pandemic exposed huge gaps in our system, and you've got to think about it. It's been 30 to 40 years since the healthcare delivery system had some sort of evaluation and change in the system. So hopefully, I'm encouraged that this will be a model moving forward. And how do we infuse healthy change and deal with some of the things that are glaring for our system and our society in general?
Thank you very much. Thank you. With the last few minutes of our time together, we did ask that each panelist prepare closing remarks. When we finish with the closing remarks, if we have time, again, we'll get to some questions maybe that are in the chat. But you were asked to prepare questions relating to responses to questions relating to what are the most important lessons your organization has learned about the pandemic that you could undertake in the next 2 years that would have the greatest effect on the health of the community in that time period. And what do you see as the greatest challenge for your organization in the next 2 years? And what are some of the recent high points and achievements at FHN and at SSM Health? And let's begin with Chief Operating Officer Martinez, and then go to Dr. Parks, and then to President Miley.
Thank you. Again, I want to thank everybody for this opportunity. Most important lessons that we learned. As an independent community organization, we were able to be agile and adaptable, and we have to keep that spirit up. We've got to take every positive lesson we've learned and every negative lesson we've learned about COVID and the pandemic, and we got to keep moving and improving the delivery of care that we have for our community. The second opportunity for us is to continue with our partnerships and our collaborations. We never worked as closely with our county health departments as we have in the last 2 years. It gave us all a very much better understanding of what each other's roles and responsibilities are and our responsibility to the community. So we need to continue collaborations with our partners. From a greatest challenge perspective, I think we have two. The largest glaring challenge healthcare organizations across the country are going to have is workforce. We've got to figure out how to get new people engaged in our workforce. We've got to bring people back in, and we have to think very differently about who can do what. We're already thinking about what are new roles, what are new opportunities to get high schoolers in, to get other people engaged that haven't thought about healthcare. And then I think one of the biggest challenges is our unknown about the long-term effects of COVID-19. Because it's a disease that has impacted young and old alike, we are going to have more young population individuals who have chronic conditions. We know chronic conditions impact not only our workforce, but it impacts family life, it impacts our healthcare systems, et cetera. So we've got to prepare, and unfortunately, we don't know what we're preparing for just yet. So again, that's where agile and adaptability is going to be our friend. And then some of the recent high points, uh, amidst the pandemic, we opened up a new cath lab. We have new cardiac catheterization equipment. We renovated our operating room suites. We cared for individuals. We call it Apache scores. It's a score that our patients get in the intensive care unit. It tells you how sick they are. Our scores were higher than the Rockford hospitals and equivalent to the University of Wisconsin-Madison at times. That is impressive. And, our team was amazing. Everybody's going to tell you their teams are amazing during this pandemic. But boy, we rose to the occasion, and I feel we served our community and we live true to our healthcare vision for our community vision. Thank you.
Thank you. Dr. Parks?
Yes, so I think one of our greatest lessons are multifaceted, and I think our other panelists echoed this as well. But as an organization, we had to learn how to be very nimble and adaptable. That is huge, and it was incredible because during COVID, this was sort of like a moving target. There were many uncertainties during this process, but we knew that we had to be adaptable. We knew that our initial protocols of care, when there was evidence and making changes based on the evidence, we had to do that rather quickly and rapidly and get that information to our care team. The other huge lesson is, and I will talk about this multiple times, is we learned that we had to be able to reach our patient and our community population where the needs were. We had to expand, and we have to continue to work on expanding access points. We talked about the ushering in of telehealth. That's one point and parcel where we have to look at ways in which we can employ that in several positive ways, because we realize that there are certain patient populations that will employ that a little bit more than others. So being able to reach our patient and our community and expand access points. The last part in terms of the biggest lesson was we learned how to collaborate with our critical care partners, because we knew, as Kathy mentioned, we were it. We were going to be that point to provide exceptional care because all of the other referral facilities were full as well. So we knew we had to develop processes that would not only support the highest level of care here locally, but then also support not only our staff. Transitioning into the greatest challenge that I think we will continue to face is social determinants. And that ties into reaching our patient population where they're at. But we have to never forget that there are certain things that we have to begin to find novel ways on addressing so that we have a positive impact on not only healthcare delivery, but a healthy community of all of its members. And the other challenge, Kathy stole my thunder there, was we're going to learn so much about the long-term effects moving forward on this devastating illness and infection. Long COVID is something that we will be dealing with for quite some time, and trying to find some sort of linkage to optimal care. That's one of the things that is of particular interest to me. The last part was, what are our greatest high points? I can tell you that I've been involved in providing critical care to all of these patients that enter our doors. One of the things that I was quite proud of was that I can truly say that most of our physicians that were on the COVID advisory group, we worked night and day. I was managing all of those vents and watching each and every member of the care team, down to the individuals that were cleaning our rooms, the individuals that were providing support, the individuals that were providing respiratory care, all the way up and down that spectrum of the care team. They were devoted and dedicated individuals. And as Kathy mentioned, the critical care numbers that we were providing, the Apache scores, which is the level of acuity in critical care, our numbers were resembling our partners at UW. So we were quite proud of that. But the journey doesn't end at this point. We have to continue to see how we can remain nimble and how we can transform healthcare with all of the lessons that we've learned.
Thank you. Thank you. And Dr. Miley.
I think the crucial lesson, and you've heard it both from Dr. Parks and from Kathy, is the speed of change. In healthcare, we've always been very precise. We take things step by step by step, to make sure they're implemented in the right way. We didn't have that time. We would have information change so fast in a day, it almost felt like instant obsolescence. You heard something an hour ago, an hour later, it's no longer valid. And so our staff were constantly in this learning mode, but that was one of the miraculous things we learned in healthcare is we have the ability to change much faster and improve care much faster than we ever thought we were able to, and yet keep it safe. And I think that was a huge learning from it. They both have spoken to the long hauler issues, but I really think also the pandemic is going to challenge us over the next few years in terms of the backlog, the cancers that weren't caught early, the other chronic conditions that weren't caught early. But I especially am worried about mental health. The pandemic showed us a lot what the isolation was doing to mental health, and really highlighted we need to expand those services, and yet it's not one of the areas that's funded well for us to be able to do that. So I think that's going to be our challenge moving forward, is how do we provide critical services that in the past weren't recognized that way, and again for all, and how make sure we're outreaching to those communities.
Thank you very much. We have come to the end. However, we do have a couple questions in the chat that I would like to share. One is, what is the panelists' opinion about healthcare for all or a single payer insurance system?
I agree with Kathy. That's a whole nother topic. That is absolutely huge. And I think there's there'll be a lot of politics associated with that one also.
And the last part of that was, when the next pandemic occurs, what would you most like to see in place? And we'll go to, well, either one, anyone can answer that.
So I will take that. So I think that there are several aspects that we'd like to see in place. I think that recognizing what the uncertainty is that problem, right? So we don't know what lies ahead, but what I would like to see is more of a commitment to the community health and public health in this country. I think that over the years, that was one of the things that we felt that was always up for debate in terms of whether or not we need public health initiatives, whether or not we need public health resources. But we realized that we don't need it until we really need it, and it exposed a huge gap in the system. So that may be an opportunity to evaluate and fund that a little differently.
Okay. Does anyone else want to add to that?
I think, one of the challenges that we have now is social media, and it's that immediacy of release of information and opinions, et cetera. And it's unfortunate because I think we experienced a lot of challenges related to this pandemic because of either misinformation, mistrust of who was spreading the information. And as Jane mentioned, healthcare traditionally is very evidence-based, very scientific-based. And this really caused us to be, we had patients arguing with us, that, no, I don't have COVID, as you're getting ready to put them on a ventilator. And I look back, I'm an old nurse, right? So I was there when HIV started to come out into, we had a lot of unknowns about it. but there wasn't social media. And there was only one news feed that came out at 5, maybe 6 o'clock at night and 10 o'clock at night. And it really allowed the messaging to be somewhat controlled. And I don't want to minimize messaging, so please don't take that out of what I'm saying. But I think it, a much more concerted effort where people can truly go to someplace for the source of truth and make their own opinions would help us. And I'm really hoping that by the next pandemic, we've got a lot of other things sorted out. Because I don't think any of us are ready for another pandemic outside of this one.
Absolutely.
Thank you. Thank you. There was a question about the CARES Act, and that's probably another lesson as well. And then the final question was, do the lessons of COVID suggest that we need a healthcare equivalent to banking's FDIC?
I think it's an interesting concept and question. I think the hard part is everyone's at such different levels of what they can afford. And that's part of the whole access piece. So FDIC says, if the bank fails and you have this much money, we'll pay you back, is a lot of what that insurance does. So what do you do if someone can only afford $100 a month and another person can afford $500 a month? Where do you put that limit? So I think that's going back to Dr. Park's discussion on social determinants of health. It would be tough to set one level like FDIC does. I think where they're going with that concept has some things to think about, but more on the health provider side versus on the individual, protecting the individual.
Would anyone else like to add to that?
I agree. I think that that's probably a novel concept, and that goes back to lessons learned. How do we support or even transform the healthcare delivery system so that it is more robust in times when it's stretched to its limit? So part of that is the true hardcore economics, right? So we have to figure out ways, how do we scale up and still be within certain constraints, and how do we operate right in the area under the curve, so to speak. So it is a novel concept. It might be one worth looking at, but I'm not sure how well that would play in the future. So.
All right. Does anyone have any last comments they would like to make?
I'd just like to say thank you for letting us have this discussion tonight. It was very enjoyable.
Great.
Yes, I just want to say thank you as well, and look forward to implementing learning lessons. And if there's feedback that any of you can give to us, I'm sure both Jane, Dr. Parks, and myself are all willing to collaborate and really help us get a healthier community.
I would echo that. So thank you once again for inviting me. And I think that this is a healthy conversation, a healthy medium to actually discuss some real world topics. And hopefully we'd be able to exchange this and continue the conversation, because the one goal that we all share is a healthcare system that serves our community so that we have a healthy community and we have a positive impact on that.
Absolutely, absolutely. Well, I would like to thank our panelists on behalf of the League of Women Voters. Thank you so very much for the depth of your responses. We thank you. We thank all the members and of the League of Women Voters, as well as the other members of our audience and members of the NAACP for attending. And we certainly want to thank the League of Women Voters Program Committee that organized this event. And once again, I'll say thank you for asking the NAACP to co-sponsor this event. At this time, I am going to turn the program back over either to Carol Dickerson or to Sharon Cook.
Okay, well, thank you very, very much. All of you, so well done. such thoughtful answers to the questions. Thank you. Your lives are so busy already, and you took time to not only come tonight, but to prepare, and we really appreciate that. I want to thank Pat Norman for excellent job. You're so smooth and expert at this. And for the people who work behind the scenes in technology, Laura Watson, and for Carol Dickerson and Deb Lishway in coordinating this also. Thank you very much. And we'll wish you all a good night and safe travels if you're going home somewhere else.
Thank you.
Good
Thank
night.
you. Good night.